Good morning, friends. Good morning to the Journal Club. Yet another exciting program. We are starting from this week. It's a very innovative program. Many friends have already joined. I see that still more friends are joining. And also, this program is being streamed on live on YouTube. The many friends are also on the YouTube. One happy thing is, I must not say just good morning alone. I should also say good night because I see that many friends are joining from different parts of the world. Also, we have a quite international audience, even though it is very small. Thank you very much. Sparing some of your time in this early morning. I think I woke you up very early in the morning. I please forgive me for that. Anyway, I'm so happy you're all so much committed for the research and academics, and you're able to join this morning. Thank you very much. So before we continue for the program, some meeting etiquettes we should follow. That is kindly mute your microphones. You have an opportunity question whenever you want. You can stop us whenever you want. You can raise your hand, and you can ask me to ask us to to speak up. You have the right that right. So you just raise your hand, and we will allow you to speak. Okay. Otherwise, please keep your microphones mute. Okay. So if you want to alert us, if you want to ask a question, just raise your hand. Okay. We will or put it chart in the chat area either to me, any of the faculty. You can ask them direct questions. That is the second thing. And third thing, of course, we are going to have a discussion in the end. And if you have a suggestion to make, an advice to make, you're most welcome all the time. Friends, be with us. Okay. Yeah. Thank you very much for being with us. Okay. With a small introduction, uh, I would like to declare in the beginning itself, we have no personal conflict of interest as far as this event is concerned. We have not received any financial support from any of the companies. And the main sponsors of this event are mainly our medical college, Basveshwar Medical College and Hospital Chitradurga, Karnataka END Hospital and the Research Center, and Champions Educational and Medical Society, Chitradurga. So we would like to clarify that this thing. So why this event? If you ask me, I saw some time back a circular, sent by NMC about the uh, the papers requirements, publication requirements for appointments to promotion and appointments. I think this was a game changer move by NMC, I would say, as far as to develop the research acumen and research environment, to enhance the research environment in the course. The other game changer point I noted was a compulsory course on biomedical research for all medical teachers. See, I was at PJ Chandigarh as a resident. It was compulsory for us, all of us, to pass this, go through this course and pass this biomedical research before we submit our thesis and appear for final examination. We were lucky to do that during that time, but NMC has made it a point to make it compulsory for all faculty and also postgraduate students. I think this is another game changer point I noted. I hope this will also brought down to the UG level. I think research is somewhere should be, we should inculcate that research acumen and research aptitude at UG level, I believe, because I also had an opportunity to spend about 2 months at University of Pennsylvania as a researcher. I was trying for in residency at US. I couldn't get into ENT residency, but I could get into the research program. I realized that undergrad students come to the research laboratory in America. I think same kind of thing should happen, and we should develop. I think the our students right now. That's what I believe. This is one point I'm going to ask our esteemed guest today, who also happens to be the president of Ethics and Registration Committee, Professor Achal Gulati, about his opinion on this. The other thing which I noted, the third important point, a game changer, which I believed was very important, is revised medical education technology, which is compulsory for all teachers, specifically thesis guides. I think that is another game changer. So with this preamble, with this introduction, I would like to move on to the next course, that is who will be inaugurating our program. None other than one person I would envy to be in his shoes. You take what a person can be served in multiple facets, multiple ways, and multiple positions which we all can be involved. He has served till today. He has been a teacher studying from undergraduate level and to the postgraduate level, then being head of the department, then a director and principal of a medical college in the capital of India, New Delhi, and now he happens to be the president of Ethics and Registration Committee at the National Medical Council, none other than Professor Dr. Achal Gulati. He's here, sir. Good morning, sir. Welcome, sir.
Hi, Prahlad. How are you? Good morning,
I'm fine,
everybody.
sir. How are you, sir?
Good, great.
Thank you very much to take out some of your time today, precious time today, and be with us and inaugurate this program and give some of your vision statement of NMC as well as your personal vision statement as far as thesis concerned, sir. Sir, welcome to the program, sir. So next we have is friends, our journal, our mother journal, one journal which is there to say like it is ours. That is Indian Journal of Otolaryngology, Head and Neck Surgery. When I was an undergraduate student, a PG student, we had to search for these journals. Where are the copies? Are they available somewhere? Who are the authors? Who is the editor? It was almost a non-existent kind of journal. It was one person who gave a shape to this journal and made it an indexed journal, a reputed journal which other people also cite the journal, articles from the journal. Complete credit goes to one person, Professor Dr. P.S.N. Murthy, who happens to be the principal at Pinnameni Siddhartha Medical College, now on to Vijayawada. But what I remember is a long time faculty at Kasturba Medical College, Manipal, and he has agreed to be an adjudicator for all these journal clubs, and he is going, he has served as a editor of the journal, and he knows what are the right papers, wrong papers, which papers have credibility and integrity, which can be accepted, not. He has gone through that process for a long time. Who can be a good adjudicator, as far as this journal club concerned, and he's joined with us. Sir, good morning, sir. Welcome to the program.
Murthy, morning, brother. Thank you very much.
Thank you.
Morning, Achal.
Hi, hey, how are you?
Yeah, great camaraderie here, sir. Thank you very much. And guest of honor today, none other than our own Bharti ma'am, we call Dr. M.B. Bharti, Association of Otolaryngologists of India. And if I go on, say good things about it, I think it will take more than 1 hour, entire hour journal duration. She doesn't require any introduction. She organized exemplary national conferences at a place, not just once, 2 times, and also South Zone conferences. And she is our first lady, I would say, and the president of Association of Otolaryngologists of India, and she is here to say a few words for us, words of this thing, our vision, also our vision about our journal and future course of action for that. Good morning, madam. Welcome to the program, ma'am. Yeah. You are muted, ma'am.
Yeah, sorry.
Yeah. Welcome,
good morning, Dr. Prahalad.
Yeah,
it's a good initiation you have taken, and you have told all the norms why you have taken that. Yeah, that's really good.
Ma'am, yeah. And I wanted to make this an AY program in the future. I want to give it over to you and do this as an AY program. I'm happy to help you in whichever way you want. Okay, I made the initiation, and just next week onwards, you should make it an AY program. I'm happy to moderate this thing, ma'am. Yeah. Okay. And we have our home team, Professor Dr. Nagendra Gowda, Professor and Head of the Department of PSM, and one genius, I said, as far as statistics concerned. I collaborated with a lot of projects, and he's here. And we have our otology fellow and junior consultant, Dr. Oshin Thomas, who will be presenting the today's article. And of course, I'm going to moderate the program. And also we have today Dr. Pawan Singhal, the man behind this paper. Okay. And he's happy to be with us. He volunteered to be here to the program, and also asked him if you can show that surgical technique, the video. He happily agreed for that. I invite him also for the program. Dr. Pawan, welcome. Are you there?
Yes, sir. Thank you so much.
Thank you. It's very much for that wonderful paper, Pawan. With this, friends, let the show begin. I invite Professor Achal Gulati to say his inauguration introductory words and also state his vision statement for publication, future publication for India, and as far as medical fraternity, medical faculty concerned, sir. Welcome, sir.
Thank you, Prahlad. A very good morning to all of you. Prahlad is a very hard taskmaster. On a Sunday at 9 a.m., collecting everybody, I think, is a skill and an art. Morning, Dr. PSN. Morning, Dr. Bharti. Morning to everybody online on this momentous occasion. Let me look at it as a momentous occasion, because whenever a dying skill is rejuvenated, it is an occasion to celebrate. Journal clubs over a period of time had begun to lose their significance because of the attitude which we normally had. If we look at it today, our medicine is entirely a different world. We have come down to evidence-based medicine. But then what is evidence-based medicine? Over a period of ever-evolving science based on research, we entered into an era of this so-called evidence-based medicine, which aims to supply and apply the evidence which is gained by a scientific method to change our current medical practice. And this evidence-based medicine lies on the foundation of research. Research is a very peculiar word. When I was graduating from PGI Chandigarh on the convocation, our director that time said, India is a very good country for research because we tend to research what has been searched many times before. A good statement, a wrong statement, a mix and match of the two statements. So if I look at it this way, research could be a positive research, research could also be a negative research. It is not only when I should operate, which is important, it is more important to know when I should not operate. This statement, if you look at it, so it is not only important to find out what works, it is also important to find out what does not work. This was highlighted in the recently COVID time, which we saw. We saw a host of medicines coming in, drugs coming in, injections coming in, immunotherapies, plasmas, everything coming in, which initially was very good, later on was very bad, initially was introduced, later on was removed from the essential list. So all this thing highlights one thing. The amount of papers that came across during the COVID times, good papers, bad papers, all of them highlighted the importance of bringing about a good methodology for research. And it was with this in mind that some time back, long time back actually, the then Medical Council of India introduced the concept of having a mandatory paper in the published media so that we could encourage our researchers to come across. Why are medical journals important? They are important because national medical journals, they focus on local clinical problems also. We have international journals, we have national journals. So when we look at national journals, they focus on our local problems. Something what is seen in India may not be seen in the US. So in the US journals, what I want to see in my country may not be brought about. So that is another area which needs to be thrust upon, the national journals. And I think for that, PSN has done a great job. In fact, not only PSN, the entire gamut of all the editors which have been in existence since the time the journal has been there, I think each one has contributed their might to improve the journal. And PSN has brought it to a level which I think is reaching a stage when the next person is going to have difficulty in targeting a higher situation. So what is again an issue over here? When we look at the healthcare systems to function normally, optimally, the best current evidence must be transferred between the people. Now, who all need to be transferred? It needs to be transferred from those who generate primary research data, from those who synthesize this data into evidence, for those who interpret and make the evidence-based recommendations, and those who use and evaluate these recommendations in clinical practice. Now, once we have these ideas which are clear, the question that comes is somebody may ask, why the hell do you want the articles to be published? Well, they need to be published because we need to communicate our scientific work and our research findings, increase the awareness about the disease or the treatment options. They also need to influence the clinical practice, support by marketing claims, which a lot of companies do, and guide the future research. You see, if you go back into history of when the net was not there, when the only way to present your papers was to travel to a conference, if you look at Caldwell Look, 1901, 1904. Now, these two gentlemen, one in Europe, one in the US, brought about the Caldwell's operation and the Luke's operation. Now, both of them presented in the same conference at a gap of 4 years when they first described it. But then the international conference, which was held at a time when both of them presented their paper over there, and therefore it came to be known as the Caldwell-Luke's operation. Had it been the time when the internet era was there, the day they made it, Caldwell would have done his job, Lutz would have done his job, and whoever was there who ran first in the game would have got the surgery according to his name. So things have changed, how they present and how the things travel fast. What is a journal club? I think Prahlad has hit the nail on the head for the requirement for today. It was a very interesting thing long time back. But then what happened? The internet took over and the keenness to know about the latest literature was available at the touch of the finger. At that time, we had to go to the library, we had to look for journals, we had to subscribe for journals, we had to write letters, which were physical letters to people to give us their article reprint, and so on and so forth. Maybe from Chandigarh, maybe from Delhi, or maybe from anywhere part of the country, travel to the National Medical Library to look up at the journals. But then internet brought the journals at the tip of our fingers. But then we also need to have the science of discussing what happens in the journals. And that is the responsibility of the journal club. Now, it is an opportunity for our clinicians to learn the principles of evidence-based practice through posing a clinical question. Not only the question, it also helps us to search the literature and do a critical appraisal. When I talk about critical appraisal, I talk about critical, good points good, bad points bad, and not criticismal appraisal. Criticismal appraisal is what should be left to the opposition in the parliament. Additionally, it also offers an opportunity to hone the presentation skills and receive a feedback within an internal forum. Now, this is very important. So that is what the importance of a journal club comes in. That is what the importance of the publication comes in. That is what the importance of research comes in. Prahlad mentioned, is it at the level of postgraduate or is it at the level of undergraduate also? Well, the NMC introduced the competency-based medical education. Now for the UG, it brought about that. And even the postgraduate is now competency-based education and also the skill evaluation at the end of the training course. So when we look about at the competency-based medical education, even for the undergraduates, the issue about how to use the computer, how to use the search engines for research purposes, how to write a project, how to develop a system so that it can be analyzed and bring about a critical thinking, which is important. This is brought about in the foundation course when a student joins his MBBS. Now, foundation course is for the first month when he joins the medical college. It's a sort of an extracurricular, which so many other things are dealt with, your computer skills, your yoga, your exercise, your ethics. So all these things are dealt with it because this is what is going to be the hallmark in future. Prahlad mentioned that in PGI, we had a biomedical ethics course. It is not only the biomedical ethics, we also had a statistics course at that time, which we had to clear. And apart from that, what the NMC has made mandatory, every medical college must have an institutional ethics committee, which is mandatory. It must implement the competency-based medical education. So this is what it comes out to. So the question is, what purpose does the journal club serve? I think this is what Prahlad would have had in mind. We need to teach and develop critical appraisals. We need to increase the exposure to rapidly evolving medical literature. What was, what I learned in recent advances of medicine in 1982 when I was doing my MS, probably today is all history of medicine. And it has taken this short a period. And with the computer and the internet in place, I think probably the future times to come, there is going to be no time lag when recent advances turns into history of medicine. It helps in informed medical practice and facilitate better knowledge. Also, it helps to bring about evaluation, analysis, discussion, and an attitude in the individual, how to progress in respect of science. The question is, why should we publish and what should we publish? Let me go in a little negative direction on this Sunday morning. What we should not publish, what we should not do. We should not submit duplicate publications. I submit one article in one journal, second journal, third journal, and then I have 3 articles to my credit, maybe with a little bit of a modification, but then in the title, but I have cluttered the research, the environment out there with my seamless, utterly non-required articles which have already been published once. Falsification and fabrication of research data. Now, the other day I saw an advertisement. I was just passing by a market near Delhi University where a lot of thesis work was being done, and they said, we write thesis of all kinds, category A, category B, category C. And what was that category A, category C? A was written by the professor of a medical, not a medical college, by an institute, and which had some amount of original data. While category C was just rephrasing of a thesis which had already been done before. So these theses are available in the market for there. But should we have this data? No, it is a falsified data. Should we have this publication? No, it's not a required publication. Plagiarism, that is something which is very, very sad at times. Copy paste. Now the computer has made it very easy to copy and paste, and finding it on the literature on the wide world web over there is very easy. And I just hope that somebody does not see this article, so I copy and pasted it. But then this is something which is the lowest form what we can try to as far as the publication is concerned. I'm sure PSN would be seeing a lot of such issues which come across, and this practice of using somebody else's ideas, somebody else's words in your scientific writing without giving them due credit is passing off as a own publication, is plagiarism. Now remember one thing, it's not that I have published an article in another journal and I can use that as a reference point in today's article. No, even using my own text from other publications in the current writing without referencing, giving the reference over there is known as self-plagiarism. So I can even self-plagiarize my articles. Authorship conflict. Now, I have done some work and somebody else publishes the article. There is a conflict over here. I mean, there should be no conflicts as far as authors are concerned. Whoever has done the work, whoever has contributed to the article must get his name over there. And we must give the credit to that. So anyone who has done the research methodology, the data analysis, the drafting, revision of the article, doing the clinical work, it must be there. But then let us not have a big barat of people over there, having 25 people in a case report, which just lasts for one page, and one page is full of the people who have worked on it. No, we have to have a very set criteria for that. So when we should not include the name of a person who has, we should always include the name of a person who has contributed, and must obtain the consent of the individuals before we are publication, and avoid something known as gift authorship. Now my wife, my child, my son, my brother, my sister also need the publication. Okay, add your name. Somebody else comes, my brother-in-law is due for promotion. Can you add him? Okay, fine, let's add him. No, gift authorship, pressurized authorship, ghost authorship, these are something which need to be avoided. And this is what the NMC looks at when it looks at the various journals and the indexing agencies which go through them. Salami publications. I make a small article, I make a small research, and then slice it into salami slices and make 5 articles, 10 articles out of them. This again is something which needs to be avoided. So we must choose our journals selectively. Now the NMC, what they did was they went through a list of the indexing agencies which had to be, in which the article had to be included. But then we suddenly found out that a host of new journals have come up, everything with the name of International Journal of XYZ. And that created such a chaos. And once the UGC committed a raid in some place in, I think it was in Hyderabad, where they found 760 journals being published from a 2-room apartment, all with the name of international standing in front of them, all being run just by a team of 4 or 5 people. Now, what is the credibility if I publish an article in that? I want an article published, there's no problem. You check your mailbox today. How many invitations do you get? We invite you to be the editor of that journal. We invite you to be a guest editor. We invite you to be a peer evaluator. We invite you to contribute. Now, these are the predatory journals which are there, which we need to look out. They are the ones who are indulging in ethical practices. They are there for the money. You give them 3,800 rupees. You get an article published in the next week. You give them 4,600. They'll publish it tomorrow. You give them 7,000. They'll publish it today itself in the evening. This is the issue with the predatory journal. This is the issue with the unethical publications, which we must look out and must avoid when we are looking at the publications. So you must learn to identify what are the predatory journals, and you must learn to avoid publishing the articles in those journals. Now, when we looked at all these things, we thought that these research had become a dying art. So the Medical Council of India, the Board of Governors, they said that for a promotion purpose from assistant professor to an associate, or from an associate professor to a professor, you must have 2 articles published in journals. Now, over a period of time, hello, yeah. So over a period of time, when we look at it, we need to see that whatever regulations are in place at that particular time, they were the ones which are applicable at that time, and they were the ones which would be applicable for an article which was published at that time. Now, let me give you an example. Before 2009, 24th July 2009, there were no regulations as to what sort of an article should it be there. So anybody, any article, whether it was a case report, whether it was a review article, whether it was research, whether it was anything editorial, any article, any authorship, was acceptable as a publication. Then in 2009 to 2010, another change came when only the first author was accepted for any article. 2010 to 2017, another regulation was in vogue. That time only the first author and the second author was acceptable. And over here, it was basically the original research and case reports and review articles which were accepted. Now there were flaws over here. So 2017 onwards, again, the norms changed. So we said, okay, fine. The first author or the corresponding author will be there and their issue will be taken into consideration. So second author was removed. So initially we had any author, then we had only the first author, then we had the first and the second author, and then you had the first and the corresponding author. And then 2015 to 2022, it was the first or the corresponding author with the original research. Then 20 onwards, what happened was that first three authors or the corresponding author will be given the credit for an article. And over here was what was important was that it was only original research papers, meta-analysis, systematic review, case series, which are published in journals and which are also included in the Medline, PubMed Central, Science Citation Index, Expanded Embase, Scopus, and the Directory of Open Access Journals. These are the only ones. Copernicus has set all out because it was seen that every TDH journal, Tom, Dick, and Harry journal got their name included in so many indexing agencies just because the MCI rule had said it must be an indexed journal. So what is an index? I can index a journal even in some newspaper index or something of this sort. So that is why the current norm which is there is that you must have only in these 5 indexing agencies which are there. Now, this is not the only thing that you must have. Apart from this, you must have what Prahlad mentioned, the basic course in the medical education technology and the biomedical research, which must be approved by the ICMR. So if you look at it, all these issues were addressed. And now the current thing is that for ideally during your residency training, you should present a paper in a conference, should write a paper, at least get your thesis written down over there. That is the desirable norm for that. Actually, there is a norm that says that you will not appear in your examination till you have such a thing. But then at present, in the current scenario, the NMC, the National Medical Commission, overlooks that a little bit more on the lenient side because of the COVID times, but you must at least go to that practice. But from an assistant to an associate professor, 2 articles in the thing what I've told you must be published, and from an associate to a professor, it must be published. Now, keep in mind, whatever regulations were in vogue when you published the article, that would be the regulation which is applicable to you. So I cannot say that I'm the second author at this time, therefore I should be accepted. When my article was published, if that time the second author was not acceptable, that article would not be acceptable. So just look at it from this viewpoint. So when we look at it, we must go across that we must not do any flawed publication. We must go in for peer-evaluated journals so that no made-up findings, no hoax results do not have a proven scientific basis, don't come into the market. Apart from that, there is also a peer evaluation serves another important purpose. Dangerous conclusions, dangerous recommendations, dangerous findings that could harm the people. These should be taken with a lot of care before the publication goes in. And if they are only correct and true, they must come out in the scientific literature. Otherwise, it spreads a very wrong message. If I cooked up a data for looking into a commercial aspect of this, because it is a sponsored result, it is a sponsored paper, therefore I must bring out the result. One has to be very careful on that. So these are the issues which need to be looked at, and we must complete our courses, and we must indulge in having such journal clubs which are important in our day-to-day activities. We must indulge in routine research works which are there. The main aims of a doctor are clinical practice, teaching practice, and research practice. All these three things are very important in our life, and we must indulge in ethical practice, ethical research work, ethical clinical work. If we just stick on to that, I'm sure we are going to go do a great job. I'm sure Bharti is going to look into all these aspects as she steers our association forward. And Prahlad, with his brilliant ideas, I'm sure with such things coming out, is going to do great guns. And PSN, heading with the journal, which has been his responsibility, which had been his responsibility, I'm sure his contributions are going to be really phenomenal. Thank you so much for being for letting me be with you on this Sunday morning. It's a very sadistic time, but then it was Prahlad's order that we do it at 9 o'clock. Here I am, Prahlad. Thank you so much.
Sir, thank you very much, sir. You nailed it. I think the most important aspect of your talk was, stressing upon the negative points. I think that's where we should look upon. I think the new guidelines will go a long way in enhancing the quality of research, medical research in India. I'm sure about it. I missed on that one important thing, foundation course for UGs. I think that is another game changer. I think that will go a long way in inculcating a research aptitude in undergraduate students. With this, Bharti madam, a few words from you about your vision, for the future course of journal. I should have called the editor and editorial chairman, then I thought it will become overcrowded for the first meeting itself. I'm going to call them for the subsequent meetings. And your few words, ma'am. Bharti ma'am, are you there? You have to unmute yourself. Hello. Madam must be busy somewhere. Hello. Okay, if we'll talk to madam again. Bharti ma'am, are you there? Yeah, if not there, we'll start with the journal presentation. Dr. I request and I welcome Dr. Oshin Thomas to share her presentation. I have stopped sharing my presentation. Yes, ma'am, you can share your presentation now. Now, the presentation is like this. Our fellow, she's going to present a paper, and we are going to hold at every slide, and we're going to discuss the nitty-gritties of the points being discussed there. Dr. Oshin, yeah.
Good morning, sir.
Yeah.
Good morning. Good morning, sir. Am I audible?
Yeah, you are audible.
Yes.
Perfect.
Good morning, sir, and all the senior faculties. Today, let us start with the journal club.
Yeah. Dr. Oshin, will you give me a little bit time?
Yes,
sure,
sir.
sir.
No, let's make some ground rules.
Yeah.
I mean, Prahlad, a very good initiative, a new initiative. The most important thing is the need of Java.
Yes, sir.
So, thing is, Ocean, we are in a very irksome position because the author of this particular article is also online. Right?
Yes.
Yes, sir.
So, Pawan, with the due regards, comments made are on the present publication or published article, but not on anything else.
Yes.
Pawan, are you there?
Yes, sir. I know, sir. I really require critical appraisal of this article so that I can improve my article writing further.
We are only appraising the article.
Yes, sir.
Not anything else. Not the
I'm rather honored to have this article being discussed, sir. Thank you so much.
Right. Question, because with that, I think we can start.
Thank you, sir. So let us start with the journal club. Okay. Today's article we are going to discuss is an article which was published in the Journal of Laryngology and Otology, and the title of the journal is Total Annulus Excision Tympanoplasty: A Solution to Recurrent Meningitis, a double-blinded randomized trial. So this is the topic of discussion today. Now, coming to the introduction.
Can I ask you a question first?
Yes, sir.
Where did you choose this article?
Sir, this was sir from net only. Sir, Prahlad sir has shared me, sir, for the purpose of today's discussion, sir. So I have read the original article, sir.
No. Is there any specific reason why you have chosen this particular article? Not because Prahlad has given you.
Sir, actually,
sir, honest confession, I selected this article for several reasons. So for several reasons. One is,
I know that I want it to come from her.
I think she chose because I sent it to her. Yeah.
Sir, this article sir has sent me, and sir, I found it interesting, sir. So I had studied it detailed after that, sir.
You are which year resident?
Sir, I am a junior consultant and an otology fellow. I am working with Prahlad sir as a junior consultant in Karnataka END Hospital and Research Center, sir.
Okay, right. This question doesn't apply to you.
Sir, so this is the topic of the discussion today: total annulus excision tympanoplasty, a solution to the recurrent meningitis, a double-blinded randomized trial. Now, coming to the introduction, otologists have refined various tympanoplasty techniques, of which the underlay tympanoplasty is the most widely used technique. And in the various tympanoplasty techniques used, the success rate has been described in literature from 74 to 97%. And in the various techniques used, a discharging eardrum post-operatively, mostly known as recurrent meningitis, is not uncommon. So the author in our present discussing journal, they have introduced a total annulus excision, which is a type of interlay type of tympanoplasty, where they have able to get no cases of recurrent meningitis, and they have introduced that this technique is a type where the graft is placed between the mucosa medially and the canal skin epithelium laterally, and with the removal of the residual tympanic membrane along with this annulus. So that is the introduction to our current journal which we are discussing. Now, the objective of this study was to evaluate the efficiency of total annulus excision tympanoplasty in comparison with conventional underlay tympanoplasty. Now, the study design and protocols used in the study were, first of all, it was a hospital-based study. It was a randomized, controlled, interventional study, and it is a double-blinded study.
Yeah, 1 minute, Dr. Oshin. Sir, now question to you, Murthy sir.
Yeah.
Now, as an editor of a reputed journal, so this is the study design and protocol. I hope Dr. Nagendra Gowda is also listening, PSM professor.
Yes, sir.
So how do you value this paper? Just this introduction. It's an hospital-based, randomized control interventional study and double-blinded study. So what do you look for in papers? Which study you feel a credible study as far as the study method is concerned, design and protocol concerned? Murthy sir.
Yeah. As far as the acceptance for consideration for editorial review.
Yeah.
This is a good. This article will be definitely taken.
Yeah.
The reason being, as Ocean said, the basic problem of recurrent meningitis and how to solve the problem is a current problem.
Yeah.
So anything current which is relevant to the present scenario, which is relevant to a broader population,
yeah,
definitely will be taken into consideration for a the only negative point in this is, go back to the study.
Yeah.
The study says that he is comparing with somebody else's. It actually needs an ethical approval. Whenever there are two techniques, and I'm sure Pawan has taken the ethical approval from the committee.
Yeah.
Because underlay has been a standardized gold, almost a gold standard for quite a long time, and interlay is coming in between. And we don't have any evidence-based medicine to say that interlay is better than the underlay technique. So, if you are really comparing two separate techniques, you need an ethics review committee approval. Yeah. Otherwise, this will be a good. This will be a relevant article because it's addressing a problem which is faced by many ENT surgeons.
Yeah. This article was, I remember reading that they did obtain permission from the ethical committee, which was approved by the ethical committee, which Achal sir was also, he also emphasized that point very well. Pawan, this was approved by ethical committee, right?
Yes, sir. It was approved by the
I remember reading it. Probably Dr. Oshin, she missed on that point. This was approved, sir. Yeah, thank you very much, sir. So one is, see, you look for innovative ideas. You feel, Murthy sir, you feel this as an innovative idea. And see the recurrent myringitis, it solves the major contention is solving the problem of recurrent myringitis. Okay, that is where. So you think this is novel enough, a good study question?
Yeah. Here, we are actually looking at an outcome-based study.
Yeah.
Finally, the outcome is that here the question is, the research question comes is, you have a problem of meningitis and how to solve that problem. One of the techniques is a new technique.
Hello. Dr. Prahalad, can I ask Dr. Murthy one question?
Yes, ma'am. Please, please state your name and place, ma'am.
Yeah, I'm Dr. Bharti.
Oh, sorry, ma'am. You were away for I think few minutes.
Yeah, I'm in Mumbai.
Okay. Sorry,
Yeah,
ma'am. Yeah.
No,
Yes, ma'am.
like so the one technique is evidence-based. If at all I want to introduce another non-evidence-based, can I go ahead, or what exactly is the protocol for that? Like not in this, generalized I'm asking, sir.
Dr. Bharti, the problem here is if the one technique is supposed to have an evidence base.
Yeah.
Second one is not so evidence based, but there are several studies which are given almost an equal results. You can take an ethics committee approval and then go ahead and do the work.
Okay, ma'am. Dr. Oshin, you can continue.
Can I just intervene for a minute over here?
Yes, sir. You should, sir.
You see, over here, I think what PSN just mentioned is something which is very important.
Yeah.
It is not only when a new technique is tried that there are results from here and there. When you are going to do that, the consent over here is very important, because the pros and the cons must be explained to the patient in writing and taken from him in writing regarding the search that you are going to do, regarding the surgical procedure that you're going to perform. And all the pros and cons must be explained to him that it's a new procedure. This is what I'm going to do. This is what the issues are. So you must look into all these things before you go ahead.
Very important point.
The Institutional Ethics Committee will definitely look into this aspect before giving an approval.
Yeah. They also review the consent form, I believe.
Yeah. It's an highly informed consent.
Yeah. Yeah. Next, ma'am.
Yes, sir. So the inclusion criteria which was used in the study was the age of between 15 and 55 years. Patients with 15 and 55 years patients were considered, and those patients with inactive mucosal type of chronic otitis media with conductive hearing loss and a pars tensor perforation were included, and also those patients who were fit for surgery, and also those patients who was given a written informed consent was included in the study.
Yeah, important point, and they've gone through the proper channel. Pawan and Co. I think that's very important. Yeah, go ahead.
Can I again intervene over here?
Yes, sir.
See, we've said that we have a written consent and we have given the age of participation 15 to 55.
Yes, sir.
Okay. The age of consent is 18 years, if I look at it. So the issue about the consent and the assent, both have to be there. The assent from the individual child concerned, he must be explained in his language, and the parent for the consent in this case, because he's still a minor.
Very important point. Yeah, it's parents' consent as well here in this below 18 consent. Pawan, Dr. Pawan, I think that was looked into.
Can I make a comment there, sir?
Yes, you should.
It is a routine in our practice at SMS. Whenever a minor is there being operated, we take consent of the parents or the close relative who is along with the patient there in the hospital. So this is a norm there with our practice.
Pawan, my issue over here is not the consent from the parent, issue is assent. The assent from the individual also, he's a 15-year-old child, he is capable of understanding. So it is he also who must be asked for whether he is willing to go, but this is an assent form which has to be taken. Okay, it's not a consent, it is an assent. So both the forms have to be there.
Okay, sir.
Right, PSN?
Yeah, because 15 years is definitely, he can understand what is happening to him.
Yes, that's right, sir. Yeah. Okay, next slide, ma'am.
Yes, sir. The exclusion criteria used in the study is those patients who are having previous ear surgery were excluded, and those patients with squamosal type of chronic otitis media And those patients with active mucosal type of disease were excluded. And also those patients with tympanosclerosis were not taken up for the study.
Yeah.
Also, those patients with mixed or sensory neural hearing loss, and also when the ossicular chain fixation or disruption was present, those cases were excluded from the study. Also, when the ossicular chain stasis, when could not be appreciated or assessed, were also excluded from the study.
So one point Achal sir stressed was, we should also know when not to operate. And it's also imperative that we should know when not to include these specific cases in this study, as exclusion criteria. Murthy sir, you think any other point should have been excluded in this?
No, actually, I was wondering why meringosclerosis was excluded. Probably I thought that would be an ideal indication for this condition. This study.
Pawan, any say about that?
I'll comment on that, sir.
Yeah.
Because we are removing the whole drum, whole residual tympanic membrane along with the tympanosclerosis. So it is not a variable which is comparable in an underlay or our technique of total ingress. Because in underlay, when you remove this tympanosclerotic plaque and then graft under the residual tympanic membrane. But in our technique, we remove the whole thing. So it is not a variable which is being considered. That's why we remove this these cases also, sir.
Okay.
Okay, next slide, ma'am.
Yes, sir. Now, coming to the patient allocation and the randomization used in the study, the author has used a computer randomization protocol in using the website www.random.org/integers. And group A were in the group A patients, they have undergone conventional tympanoplasty, and the group B patients, they have undergone a total annulus excision tympanoplasty. And the patients and the evaluators were blind. And the tympanoplasty approach used was post-auricular approach, and temporalis fascia graft was used. And all procedures were done by a single senior author.
Murthy sir, any take on this? So the group A means conventional tympanoplasty means the underlay technique, right?
Yes, sir.
Dr. Oshin? Yeah, that's right.
Yes, sir.
Yeah, sir, Murthy sir, here the surgeon is single senior surgeon, okay? And the blinding is patients and evaluators. Evaluators means this is who, Dr. Pawan, who are the evaluators? Yourself or somebody else?
Sir, Dr. Namita Verma, my resident,
Okay.
she was doing this thesis, this
Okay.
research she has done. So she was the evaluator.
Okay.
Only I knew by my randomization table that this particular patient is going to have conventional or this is going to have TAE. Sometimes it was very difficult for me to do five conventional in a go on a single day because randomization gives you like this. So, but it was yes.
Okay. Yeah, that's it. So, Murthy sir, any take on this?
It's okay.
This is blind enough.
All are standard techniques and
Okay. Next one.
standard acceptable techniques.
Okay. Next.
Yes, sir.
Yeah. Before that, Dr. Gowda, you think this is random enough?
Sir, double blind is
Double-blinded.
good. Yeah,
Good.
single blind, double blind, and triple blind. Triple blind is the highest this one, which will be given most emphasis.
Okay.
Double blind is also good, sir.
Okay. Thank you very much. Yeah. Next slide, ma'am.
Yes, sir. Coming to the methodology. Now, the author here has used a standard post-oral approach.
Yeah.
And
What we will do is, Dr. Oshin, we
Yes,
will
sir.
ask Dr. Pawan to present the video
Okay,
instead.
sir.
Then he says, come forward to show the video.
Yes,
Pawan, can you show the quick video for this thing? You're ready with that, Dr. Pawan?
I will have to share the screen.
Yeah. Okay. She will stop sharing for a few this thing, and you can share the screen. Now I will have to make you this thing also 1 minute. I'll have to make you the co-host also. Give me a second. Yeah, you are here. Okay. Yeah, make co-host. Yes, your co-host. You can share the.
So I'll just go to, let me take it to my desktop first.
Okay.
So that I can share that. Okay.
Yeah.
So this is gone. Go again. Now I'll share. Can you see? Can you see my presentation there, sir?
Yeah, it is there. Go to the video
Yeah.
straight. Video straight.
Yeah, I'll directly go to the video.
Yeah.
Okay. So these are in pieces. I've incorporated the figures also,
Okay.
which were made by Dr. Suri Prabhu, whose
Okay.
idea is this technique.
Yeah.
He has got a lateral thinking of this idea.
Yes.
Then I took over it as a study, double-blind study at my institute.
Yeah.
So in the first one, after exposing the external acoustic canal,
Okay.
you can see that I'm elevating the posterior tympanomeatal flap.
Yeah.
Up to the annulus.
Okay.
Can you can very well identify that.
Yes.
I'm elevating from it is right ear. Okay.
Yeah.
Or this is
Okay.
anterior, this is posterior. Okay.
Okay.
So in the next one, what is a prerequisite in this technique? That you should remove each and every bit of mucosa as well as squamous epithelium of the handle of Malleus.
Okay.
Because I'm going to bury handle of Malleus along with my fascia. And if I leave anything there, then my whole purpose is gone.
Okay.
So this is how we do it with a specially designed instrument known as Cobra instrument.
Okay.
This Cobra instrument is made of the sickle knife. Dr. Suri Prabhu at Kannur, he makes it by his own hands at his lab with the sickle knife. So one right cobra is there, one left cobra is there.
Yeah.
So it is a curved one to take each and every bit of mucosa as well as the squamous epithelium from the handle of Malleus.
Okay.
You can see a very well denuded handle of Malleus there.
Yeah, see, when you denuded, there are a lot of rocking movements. You have no fear of introducing SN last.
Sir, I am using my suction alone, if you could observe that. So
Okay.
I'm stabilizing the Malleus with suction, and with the other hand, I'm using this Cobra. And you can see how I'm doing this in the figures made by Dr. Suri Prabhu. I'm really indebted to him for providing me these figures.
Okay.
Once I have done this thing, now I'll be repositing the posterior tympanomeatal flap back.
Okay.
Then inside out elevation of the anterior flap is done. I will disarticulate the fibrous annulus of the sulcus boni annulus and elevate the anterior flap.
Okay.
You can observe that. So this is how I have elevated the whole tympanic membrane.
So you have done a 360 degree elevation.
360 degree elevation of the whole tympanic membrane has been done of its sulcus.
Yeah.
Then after doing this, what I will do is I will make a radial cut in the posterior tympanomeatal flap till the sulcus and until the fibrous annulus and stop there.
Yeah.
When I reach to the fibrous annulus, I'll make circumferential cuts along the fibrous annulus all around so that the fibrous annulus with the residual tympanic membrane is removed. And I'm left with only my circumferential flap with posterior flap cut into two pieces, a superiorly based and an inferiorly based flap.
Yeah. That is a pelvis flap door technique, it is often called.
Yes.
Yeah.
So these are two drawers I'm making.
Yeah.
I'm cutting it and then I am circumferentially going anteriorly and inferiorly up to and taking out the whole fibrous annulus with the residual tympanic membrane.
Yeah. What instrument you are using to cut that?
I'm cutting it with two things. Either you can use micro scissors. I'm using. Otherwise, I prefer an iris scissors, which is thin and long.
Yeah. So
if you observe, then you can see the medial surface of the drum, which is mucosalized, thick.
Yeah.
And if you see the lateral surface, which has got mucosa over it, that makes a purpose for this lateral thinking of this technique.
Okay.
So once I have done that, now I'll place the graft circumferentially over the canal.
Yeah.
And I'll bury the handle of Malleus in with a fold of the this graft itself.
Okay.
And then I'll reposit the epithelium all around.
Yeah.
So
See, the malleus is lateralized, right? The graft is medial to the malleus, isn't it?
The graft is medial to the malleus, but the graft is also lateralized because it is not inserted in the sulcus annulus. I'm keeping it deliberately lateral to provide a good middle ear space and the air bubble inside. So once I have done this, I have kept only a 3-layered tympanic membrane. The epithelium over it, the graft in whole circumference, and the lamina propria of the mucosa will grow under it. A uniformly thick tympanic membrane all around.
Yeah. So the graft itself becomes the middle connective tissue layer.
Yes, sir.
Yeah, yeah. We can stop sharing, Dr. Pawan. Thank you very much for showing that video. I hope that clarifies the surgical technique concept. Dr. Oshin, you can share your presentation. Yeah, you can. I think you can skip this methodology, surgical technique.
Yes.
Thing. Dr. Murthy, sir, you think this is innovative enough for technique for a international article published in international journal?
Yeah,
Next slide, ma'am.
Technique is innovative. Actually, he is adopted somebody's technique and is making some innovation on that technique.
Okay, there's one point. Yeah, Dr. Mujumdar also want to make a point to that. I will come to that later. We'll go to the statistical analysis. Yeah. Okay, ma'am. Next.
Basically, TAE was described by somebody else.
Okay, we'll come to that point, sir.
Yes, sir.
Yeah, next.
Statistical analysis. So the statistical analytical tool used in the study is for continuous variables. They were summarized in mean and standard deviation, and they were analyzed using unpaired t-test. And the nominal or categorical variables were expressed as proportion in percentage, and they were analyzed using chi-square test and Fisher's extract test. And the p-value, which is less than 0.05, were significant, and they have used a statistical calculation software of MD-Calc version 16.4.
Yeah, Dr. Gowda, you think this is good enough? We need more as far as this such comparative studies concerned?
Sir, actually, as per study design, the statistical methods employed are good. But what I felt was the continuous data, that is numerical data, would have been tested by using normality. Normality, because we are going to apply one test, that is unpaired t-test, which requires the data should be normally distributed. If the data was not normally distributed, we could not, that restricts the applicability of the test, sir.
Okay. Yeah, we'll come to that point later. Next slide, ma'am.
Can I just step in for a minute?
Yes, sir, you should, sir.
You see, this is where the role of the Institutional Ethics Committee comes into the picture.
Yeah.
In the Institutional Ethics Committee, you have a biostatistician, which is always over there, because two things are important, which have to come from input from him. Number one, what is the sample size? Now over here, if it is a randomized, this thing, what methodology for randomization is being used? What is the sample size, which is significant to give a proper result, to give a significant result? That is very important, because both the groups have to have a statistically significant number of people who are there in that group. And then what method for analysis, which has to be implied. And this must be done prior to the study, which is there. Am I correct, Dr. Gowda?
Yes, sir. Sure, sir. So, sir, actually, the sample size calculation is not mentioned in the paper.
Yeah, that's it. So this is where the role of a statistician comes into the picture while the project is being evaluated.
Yeah, I think we'll come to that sample size slide in the next slide.
Can I say a few words, sir, there?
1 minute, Pawan. We'll go to the next slide. Next, ma'am.
So here we are actually discussing the patient demographic data. Here we can see the group A contained and group B had equal number of patients taken, which is 28 each. And the age in mean plus or minus standard deviation years were 26.46 plus or minus 8.90 in group A and 27.11 plus or minus 10.93 in group B. So, and the age range.
1 minute, ma. Yeah,
Yes, sir.
okay. Other are okay, minor distinct points. I think now that sample size has been stated, 28 cases each. Murthy sir, this is enough sample size for a comparative study like this. Your point, and next, Dr. Gowda, you should also comment about it.
Gowda is a better man to comment on that.
Yeah. Yes, sir.
Sir, what I recommend to all the researchers
Yeah.
is there are many formulas where we can employ them in order to calculate the sample size for any research work which they are conducting.
Okay.
Because the sample plays an important role. If the sample size is small, we cannot generalize the results. If the sample size is too large, it will bring some methodological as well as resource related issues.
Errors, yes.
Yes, sir. So what we calculate in our department is the minimum sample size to make elegant findings.
Okay. So a study like this, what would you suggest? Like, what is the right sample size? I mean, you think this is good enough?
Sir, actually, strictly speaking, I have not calculated the sample size for this study, but the author, I feel that the author would have included that part.
Okay. Yeah. Now, Pawan, you can state. You wanted to say something.
Sir, it was according to the seed article we used, it was derived from our biostatistician, Dr. Rajiv Yadav. If you see his name is there in the paper, I've quoted his name also in the paper. So he derived this number of 28. So there were 35 patients looking at the 20% follow rates and dispersion rates. He took 35 patients in each group. And after exclusion, we had got 28 cases in each category for the study. So this is how he did. I quoted this old detail in my paper, but somehow the reviewer asked me to remove this much of detail.
Okay.
I don't know why, but I quoted this whole information in my paper. It was reviewed 10 times by the reviewer. He gave me 10 corrections. And then last thing, this thing.
Okay. So that went through a lot of review, a lot of to and fro discussion between the review and yourself. Yeah, I think that's very important. I think, I'm sure you would have followed the proper protocol. We'll go to the next slide. Yeah.
The outcome measures used in the study were first, the graft uptake, second, the post-operative ear discharge, and third, the hearing gain in terms of airborne gap, air conduction, and bone conduction threshold. And the post-operative results were compared at the 6th month by using pure tone audiometry.
Okay, 2 points here, sir. Murthy sir, only airborne gap has been taken. Is it important to take speech thresholds also? May not be very relevant in conductive hearing loss. Your take on that? In this 6 month follow-up is enough. I know this is a research topic. PGs will not have not much time to do a long-term this thing. But when you publish as a paper, is 6 months good enough?
No, actually, we need to have long-term follow-up more than that.
Yeah.
But the 6 months follow-up, at least for the first few cases, it will be almost 1.5 years.
Okay.
So actually, they should put it more than it is post-operative evaluation is between 6 months to 16 months.
Okay.
Because the first case will be followed up almost for 2 years.
Okay.
And the last case will be followed up by around 6 months. Because I understand it is a recent disease.
Yes. Yeah, I think Dr. Pawan, I know it's going to be a duplication, but I think he should also come out with a long-term results as far as this study concerned, if possible.
So this study actually it was taken as a thesis topic for my resident. So time constraint was there.
Okay.
Because you give them a topic at around 6 months of their residency, then it takes around 3 to 4 months for ethical approval and presentation in the research review board.
Yes.
So the study actually started at 1 year of residency of my candidate. So we had to finish it by 1.5 years, because next 6 months she had to prepare for exams, and there is a last date of December in our university. So we had to finish it up. That's why I kept at least 6 months follow-up. Any patient who had got a follow-up less than 6 months was not included in this study. Now we are going ahead with a consolidated large sample size study which is going on, and I'll come after at least 5 years for this with a new paper with this study. We are collecting all the data.
Yeah. Dr. Harindra Narayana from Mysore, he wants to make a point. Yes, Harindra, please.
Yeah, first of all, thank you for giving me the opportunity, Prahlad. Wonderful show, and congratulations, Dr. Pawan, on a very innovative paper. So, first, when you started off, you said that this is mainly about myringitis, and in the outcome measure, you don't have myringitis on this slide. I don't know whether it's going to come in further slides. That's point number one. And point number two is, when you think about myringitis, there are a variety of causes for it. Least of all, a small residual perforation, a patient with allergy, who has persistent discharge, natural grommet, as you used to call it. Then the choice of packing material in the external auditory canal, whether there are foreign bodies or cotton kept there, whether there's otomycosis, have these confounding factors, because your choice, the very basis of this paper is to say how much of myringitis you had post-operatively, not about hearing test and hearing results. Have you actually excluded these things or randomized these things or factored these things in your study?
No, sir. Actually, we had taken myringitis only because it was the only concern we had. Even after doing a good tympanoplasty, we used to have a few patients coming back to us with sometimes like a weeping tympanum, neotympanum. Maybe because of allergy, maybe because of recurrent URI. But there should be an answer to that. You have done a good technique. You have done under tympanoplasty, still the patient is having that wet sort of feeling, having that congestion sort of thing. So this technique was an answer to that myringitis. We had many more points along with this myringitis only, which I will later on discuss. But because the reviewer told me that only myringitis is something you should consider as a point in your study, and otherwise I had considered this hearing gains also. I had considered the graft uptake also, which is better in a total annulus excision as compared to your conventional technique. I will come to that later on.
No, my question was different. My question was, myringitis has a variety of causes. Least of all is the mucosa being lateral to the graft. In conventional, there's always a risk of mucosa being lateral to the graft, and you can have myringitis because of that. That probably is the best addressed by your technique, because of separating the mucosa from the external skin. But my question is, have you considered the other factors such as use of cotton versus use of some other artificial rayon, for example, they use use of gel foam versus use of the other confounding factors which can result in myringitis in a post-operated thing. They can actually confuse the result of the study this way or that. So that
you're
also,
right, sir. There are confounding factors which should be considered. One thing is cotton. I don't ever use a cotton ball there in any of my ear surgery. Second thing, you are saying any other rayon material or something like that. I don't use that. I use a paper on my tray of instruments so that the linen fiber should not come with my pick or my instruments. That is what I always do. So I think these confounding factors, except allergy, are not there in that.
And the otomycosis. Otomycosis.
Yes. Otomycosis, I'm telling you, happens when you do have weeping neotympanum, or something like. I think that is there because of a weeping neotympanum. Because I could not see any otomycosis till date in last 5 years of my operated cases of TAE technique. And that's what makes it a different thing, different observation for me. I will come up with a large data study later on.
Okay.
Thank you
Okay.
very much.
Next
Thank you.
slide, ma'am. Next slide.
Yes, sir. The outcome analysis of the study.
Mhm.
In the study, the graft uptake, they have compared the success rate and the failure rate. In group A, there was a 96.43% of success rate graft uptake. And in group B, there was a 100% of graft uptake success rate. And the failure was in group A, it was only one case, which was 3.57% of failure rate. And there was no cases of failure in group B, which was the total annulus excision technique. And the discharge post-operatively in group A, 4 patients, that is 14.29% patients had discharge was present, whereas 0 patients showed discharge post-operatively in the group B, which applied total annulus excision, and that was the result in discharging. And on comparing the hearing improvement, they have used a box and whisker plot where they have analyzed the preoperative and post-operative air conduction, bone conduction, and airborne gap in the same graph.
Okay.
And in the preoperative study, you can see that the blue color stands for the conventional tympanoplasty, which is group A, and the dotted red color, it just denotes the total annulus excision tympanoplasty, which is group B. And in these are the preoperative airborne, preoperative bone conduction, and preoperative airborne gap values used. So here we can see that in the preoperative air conduction in group A, it was around 40.72 plus or minus 8.72 decibels of air conduction. And in the group B, in the preoperative, they had 42.1 plus or minus 8.24 decibels. So here in the preoperative, there was a p value which was more than 0.05, which was non-significant.
Okay. Yeah. So Murthy sir, look at the figures. You think this is significant enough? Say, okay, this definitely score over the other.
No, really speaking, I mean, as actually, what Harindra pointed out is much more valid point here, because he started with an outcome of weeping eardrum. Solution for a weeping eardrum. What are all these? All these things are all add-ons rather than the primary question is answer to the weeping drum.
Yeah. So see, he states that definitely the ear discharge, which is weeping, was more with conventional tympanoplasty, almost nil with the total annulus. I think that points to
the very valuable point.
Yeah. That's a valuable point.
That is a very valuable point. We can take it.
Okay.
And the AB gap is almost the difference is significant. Statistically significant difference is there.
Okay.
But taking along with the other outcome measures like graft uptake, and discharge, you have to take correlate this results with that.
Okay, sir. Yeah. Next slide, ma.
Unless I have a question for Pawan on this.
Okay.
I mean, is there a role of the annulus? Because the annulus was sacrosanct for quite some time.
Yeah.
Hundreds of years.
Yes.
It was sacrosanct. You are not supposed to touch the annulus.
Yeah.
Or you are not supposed to. So the Anglia was the only type of surgery for quite hundreds of years.
Yes.
Then slowly we moved into the touching the annulus. Now we have come down to the point where you are removing the annulus.
Yes, sir.
By removing the annulus, actually you should not gain hearing, because the fixity of the tympanic membrane is lost. I mean, I'm just singing loud. I may be wrong.
For this, sir, I'll tell you, this graph is well in opposition in relation with the handle of Malleus. First thing is that. Second, the graft along with the epithelium, along with the mucosa. It makes a good, what do you call, a good unit, which is well adhered to the medial end of your extracaustic canal. So this is how it grows there. And deliberately, I want to give some middle space there. If we think on this line, if sometimes we used to have only technique also, in which we used to put a graft over the fibrous layer of tympanic membrane, and that graft was on the canal itself. That graft was not tucked under the fibrous annulus. Then how come that technique also was propagated for so long? I'll compare this scenario with Theodor Kocher's techniques of thyroidectomy. For 30 to 40 years, people condemned his technique of thyroidectomy, that you should not do any thyroid surgery. It is causing so much of bleeding, mortality, and all those things. Still, he got a Nobel Prize for that. And we are doing his techniques of thyroidectomy still. His technique is going with the midline Jackson's plane approach and all. We are following that. So there has to be a new technique come always, sir.
No,
and you have to analyze that by study. That's why I have published an article to analyze.
Pawan, I must confess one thing. Number one, my dream was to get an article published in JLO. It was a dream. And I fulfilled my dream in 1986. And I congratulate you for that. No, my question is, in a functional tympanoplasty, we want a tympanic membrane which is held at some point of place so that it can be mobile. Now here we are removing that. I'm just asking question.
Yes, sir.
Just thinking loud rather.
Yes, sir.
Now you are removing the annulus and the fibrous annulus only you are removing and the bony annulus is still intact.
Yes, sir.
Is the graft which you are pushing into the bony annulus is going to become thicker and then it almost becomes like a thicker annulus? I mean, probably you need to study longer periods and maybe look into that matter. Because we have the epitome, we have the mesotympanic. The annulus holds the tympanic membrane so that the tympanic membrane can vibrate.
So can I speak a few words, sir? We always talked about anterior canal blunting, anterior blunting. So we always had this in our theory, in our textbooks, that anteriorly don't elevate the annulus because it will cause blunting. But so many years, maybe now 3 decades, more than 3 decades, Dr. A.B.R. Desai has been showing people interlay technique, followed by Dr. Ashim, Dr. Satish Jain, and hundreds of people throughout India. And no concept of blunting still persists there now. This is how this annulus excision technique would make a place in our thinking process, sir. I'm telling you, because I have observed it has not caused any decrease in hearing, rather it improves hearing, which I have observed, because it gives you a trimeric, uniformly thick tympanic membrane throughout the accents, anteroposterior, superior, inferior accents. That's why this is going to be a good technique. I don't know what the future is, but this is what fascinated me to take this as a study when I heard Dr. Suri Prabhu doing this technique. And so I took this technique for a study.
I hope that was convincing to Murthy, sir. Next slide, ma. Yeah,
Yes.
we have 20 minutes past our limited time. Anyway, we'll wrap up with final word from Dr. Mujumdar, who is waiting to say something. Discussion. Yeah, next. You have any relevant point in the discussion?
Sir, in the discussion in the study, it mentioned there is low incidence of complication. There is a promising hearing improvement, and a trilaminar neotympanum was created. The new technique preserves the vascular strip intact. With the excision of annulus also ensures rich neovascularization around the graft, and the neoannulus is kept in its original place to prevent anterior angle blunting. So this was the important points in the discussion which was mentioned.
Yeah.
And also it prevents mucosalization by totally denuding the handle of malleus using Cobra, which was a specially devised instrument by the author, and also seeking the mucocutaneous junction under vision. Also, they have compared it using the other conventional tympanoplasty techniques where the annulus cannot be snugly fit into the sulcus tympanicus after conventional tympanoplasty. And also when compared to the novel technique as described in the journal, there is a less improvement in hearing in the conventional tympanoplasty. And also the author has noted, have also described that there are cases of intratympanic cholesteatoma which may develop between the layers of tympanic membrane in conventional tympanoplasty, which with the new technique they were able to avoid. And also they have advocated that this technique is preferred because it has many advantages such as no risk of blunting, no lateralization of graft, and no epithelial cyst formation.
Murthy sir, final word.
Yeah. No, I mean, it's a really good article, very very beautifully written.
Yeah.
Pawan, I have only one complaint against you because the JLO editor doesn't know that, but I know because is this a multi-center study?
No, sir. This is a single center double blind study.
Then in that case, why did you give the authorship on a silver platter to Arshad Hussain? Why
Yes,
did you
sir.
give it on a silver platter authorship to your statistician?
Yes.
Number 3, you also given it to Suri.
Suri Prabhu, Dr. Bhavani, and Dr. Sudeep. Why
Yeah.
I can explain, sir.
No, you should have actually thanked them in the article because study is basically your study.
Yes, sir.
I don't think you should give their names. You should take their names into the authorship because
Okay.
you should have given them. You should have thanked anybody for the help they have done.
Yes, sir.
So
actually, the concept was Dr. Suri Prabhu, sir, and this technique was popularized by 3 names you have taken, Dr. Sudeep.
No,
Dr.
because
Bhavani,
we also in I don't know right about JLO, but now Indian Journal we are asking actually what is the role of each of these authors in writing this paper.
I have written it in my paper, sir, that they have popularized this technique and
they have not literally contributed to your work.
Okay.
That's besides the point.
Yes,
If I am the reviewer, I'll definitely accept this article for simple reason. The content is good. The content is relevant to the present scenario because it answers a particular question.
Okay.
It is relevant to the present scenario.
Yeah.
Present scenario, and it definitely contributes to the evidence-based medicine. These are the 4 reasons why I will accept it as a reviewer.
Fantastic, sir. Okay. I mean, great words, sir. I mean, I think, see, Dr. Achal sir also made a very relevant point in this to start with. That is, you shouldn't include the names just because, you know, they are in the department, they're your friends, and they're your relatives. Anyway, yeah. I mean,
Yeah, that's what exactly. That's what
Pawan had a goodwill, you know, goodwill of this thing because Suri was, he was the kind of who started this innovator and other. Also who populated the technique across the country. Okay, yeah.
I must congratulate you for one thing.
Yes,
I don't think any time a published article is discussed along with the author.
We have a distinction as far as this is
We have the
concerned.
distinction of doing this, and I think Bharati should take a clue and do this little more often.
Yes.
Then probably people who are writing the articles will be a little more careful.
Yeah. So we are walking in your footstep, you know.
So
We looked at you as a role model as far as research and this thing concerned. We are walking in your footsteps, you know. That made me to start this journal club also. The moment I decided that you're the first person I contacted. Then
thank you.
Then I invited Achal sir to inaugurate his program because whenever he's in any meetings, he gives such a great insight in various things. Having him around is a pleasure. Actually, in fact, I asked him to do a series of program weekly and some important topics, but he's so busy. I said, spare me, not right now. This thing, okay, he's very busy. Hope sometime in the future he will be, once he is off all these responsibilities, he will be able to dedicate some of his time for the academics, pure academics. This thing. So Dr. Mujumdar sir is waiting. He wanted to say something. He has been asking since ever since we announced this program. He said he should give me some time to talk. I think he's a elderly person, kind of father of one of the fathers of ENT in India. Yes, sir, Mujumdar sir, please.
Yes, can you hear me?
Yes, we can. You are loud and clear.
Yes, I thought this singer is, I knew one singer from Ajmer, but I think this singer is not that. That singer was quite senior and now might have settled in Jaipur.
Yeah.
The thing is this, Pawan, your idea is good, but you have not studied it very, very well. The thing is, we surgeons always think about the knife and where it has to be placed. But before the knife and before whom to fight with, there is a lot of other behind the scenes study. You have not studied. The tympanic membrane is just the curtain for the middle ear. Your work is entirely on tympanic membrane. But the curtain is useful when the behind the curtain, what is happening? Behind the curtain is happening chronic otitis media. And this chronic, what you call meningitis, I was phoning up to Prahlad because in my 60 years experience, the type of meningitis you have said, we used to call it soggy tympanic membrane, soggy. And you have to clean it up often. Don't forget, we are cobbler. We are not giving the original tympanic membrane. We are making a plastic graft, and keratinocytes, migratory keratinocytes, about which still our knowledge is insufficient. But what is definite in this graft, this migratory character of the keratinocytes cannot be created. So you have to clean it from time to time. That's you have missed. I think about the tympanic rave, you have misunderstood it. You are from North India. You are I think you appreciate Indian music, tabla. Can you feel tabla? There should not be titled tympanic ring is to give the deepness to the tympanic membrane parstensa. Otherwise, acoustic property of the tympanic membrane is throwing into the winds. So please think that it is not only ENT subject. This is a multifactorial subject. We are looking through not through binocular microscope. It is a tubular thinking, but you are a great man. I appreciate you involving the authors from various parts of India. And to my experience, this is the first ever Indian publications in international journal where Jaipur to Bangalore, you have cropped everybody. That shows your magnanimous heart. Please keep on marching. Don't be demoralized by my comment. You have a soldier must correct his eyesight. Thank you very much.
Thank you, sir. Thank you very much. Nice of you, sir. Dr. Majumdar, sir. This thing, sir, Dr. Majumdar, sir, had a complaint, but he didn't say anything in the open. He said this was original thought by Dr. A.B.R. Desai. He should have been given some credit. Somehow he didn't vocalize that point. Dr. Pawan, I think you should look into that also in your future publication. Okay. Yeah. Okay. I don't know. I haven't read that Dr. A.B.R. Desai's technique and how this differs from Dr. Suri's philosophy that I will look into. Anyway, overall, this is a fantastic paper. Yes, sir.
I see my boy PSN is there. He's leading the brigade. Yes, I'm a retired man, but PSN is now Major General in the army. And so also Achal Gulati, my dear child. His father was my guru, and it is But Achal, you are putting too much fat, man. Lean down a little.
Yeah.
Prahlad is all right. Prahlad is a very conscious, physical conscious. He go to the gym every day. And Pawan, you are really lovely. I love your face. Thank
Wow,
you.
wow. Great.
Thank you so
Thanks,
much.
sir. Thank you for the appreciation, sir. Yeah. Thank you, friends. Thank you very much.
Prahlad, can I take leave
Yes,
now?
sir, you should. I was about to ask you. Yeah.
And just one small comment I have to make. My sincere desire and wish is that at no point of time, as long as I am in the NMC heading the ethics board,
Yes,
should
sir.
any case of unethical practice in publication or in ENT come to me. That's my sincere wish. And I wish everyone all the best and have a nice life and a good Sunday ahead. Thank you so much.
Thank you very much, sir, for your
Thank you so
precious
much,
time.
sir.
And thank you all participants. And
Prahlad
importantly,
sir, it
yeah.
is an honor to see Achal sir there during my paper discussion. He was my examiner during PG. He rendered a gold medal to me, and I have learned a lot of things from him.
Yes.
He is the one who is always a jovial-looking man,
Yes.
always ready to help anybody who calls him or
That's
asks
important trait.
We are honored to have ENT surgeons there in NMC, sir.
Yeah.
Literally. Thank you so much.
Thank you.
Thank you. Murthy sir, final words, any?
No.
Thank you very much for accepting.
Thank you very much. And
yeah.
No, it's a good initiative, very good initiative by Prahlad. And as I said, I mean, as you rightly said, the OI should take the lead.
Yeah. I'll ask Bharti ma'am. I think she's in another program now, busy with an important program in Mumbai, which is being organized in memorial of Dr. Abia Desai, being organized by Dr. Ashim Desai and others, Satish Jain. Yeah, Dr. Hari Shankar sir, he wants to say, you can unmute yourself, sir. Final words, yeah. He has a query or this thing. Dr. Hari Shankar Sharma, sir. Yeah.
Really, it is a great initiative, and I hope it will be beneficial for our all PG students.
Yes, sir.
Because this area is very much neglected. And if we have national level of discussion like this, it is really good initiative.
We'll make it.
I congratulate you and all your team.
Yes, sir.
And I was happy to see Dr. Majumdar's comment.
Yes, sir.
And Dr. PSN Murthy also, we were associated. So
yes,
really,
sir.
it's a good initiative, and you should continue with this.
Yes, sir. We will do it. We'll do it on a regular basis. Thank you all, friends. Thank you very much for joining this program this Sunday. We'll have another interesting paper next week, same time from 9 to 10. Join us. Please be with us. Give us ideas, suggestions. Write to us how we can improvise more and more. We'll make it a pan-Indian, pan-AOI, pan-association program. Thank you all. Thank you very much. Yeah.
Thank you. Thanks for that.
Thanks, sir. Thank you, sir.